Recording in progress. Good afternoon, dear network. Our time is 14:30, and I welcome you to today's tele-echo session, HIV-TB Echo. And today we are discussing adolescent health services in Zambia. And in the hub, we have myself as presenter and also co-presenter and also facilitator. My name is Victoria Manzi, coordinating pediatric HIV services from Lusaka Provincial Health Office. And on my right side, I'm joined in the hub by Madam Gezire Tembo, who's the country director from the Rise Up project. So together we will be discussing and presenting on adolescent health services and sharing best practices. And in the hub, we are joined by one of our panel experts. We have our very own Madam Inutu Mbangweta from Lusaka Provincial Health Office, who's the adolescent focal point person. And other experts on the panel, we have Dr. Khozya Zyambo. Yeah, so there you go. We have Madam Inutu Mbangweta. She's with us in the hub. Thank you for joining the team to discuss adolescent health services in Zambia. We'll also be joined in by Ms. Samiah Phiri, and we'll have Dr. Chalilwe Chungu and Dr. Bupe Musonda. And as we discuss, we'll also be joined in by an adolescent who's going to give his input as we discuss adolescent health services. Remember, for the adolescents, there's nothing that we discuss without engaging the adolescents. So we have Fred Kapesa, who's going to join in. And we'll also have a case presentation from our team in Winilunga to be presented by Mr. Alex Phiri. So I urge you all to participate, and let's follow echo etiquette. If you want to speak, please raise your hand or type in the chat. You can keep your video on so that we are able to interact, but please let's not be destructive, and let's mute our mics when we are not talking. So I will proceed to give, so our presentation is in 3 parts. I will proceed to give a presentation on adolescent health services. Then my colleague Gezire here is going to share some best practices from the Rise Up project, as well as we'll hear from Matero, Level 1 Hospital here in Lusaka, some best practices there, and then we'll have our case presentation. So without wasting so much time, I'll take you through the adolescent health services presentation in Zambia. So our learning objectives, we have 3 learning objectives. The first one is to describe adolescent-friendly services in Zambia. The second objective is to outline challenges in accessing reproductive health services among adolescents. And the third objective is to share best practices from existing adolescent-friendly space models in our country. So before we go any further, we are going to have a poll. And our poll question reads, true or false? An adolescent-friendly space provides basic health information, distributes information, education and communication materials and contraceptives, and provides guided referral to health services within the health facility. So is this true or false? So I'll share the poll. So the poll has been launched. Please let's participate in the poll. We are not able to see how you have voted. We just want to have an idea of what we understand an adolescent-friendly space to be, what services are provided. So we have 138 people logged in, and so far only 10% have participated. Please let's participate.
That's the wrong one.
Oh, this is the wrong one.
Yeah, put 3. Let's go back to the point.
Okay, apologies for that. I'll relaunch the poll.
Oh, that's 3. So you just go back there.
I see. Yes. It was the one that was.
Yes.
Okay, so I've relaunched the poll. Please let's participate. True or false? An adolescent-friendly space provides basic health information, distributes information, education and communication materials and contraceptives, and provides guided referral to health services within the health facility. What are your views? So far, we have 49% of the network participating. The participation is very good. I'll end the poll in the next few seconds so we can participate. Okay, I'll end the poll and share the results. So when you look at the way people have polled, majority of the people think this statement is true. And we have a few, only about 3 people that think this is false. So as we go on, we'll be able to see from the presentation. So we'll start with some definitions before we go into our discussions. So an adolescent is a person who's aged between 10 to 19 years, and this is according to World Health Organization. A young person is defined as a person aged between 10 to 24 years. So in our discussion, we may refer to adolescents and young people, and in this case, we are referring to those who are between 10 to 24 years. Some more definitions, an adolescent-friendly health service or adolescent-friendly health services, a combination of high-quality services that are relevant, accessible, attractive, affordable, appropriate, and acceptable to adolescents and young people. So when we talk about adolescent-friendly health services, this is what we are talking about. And we'll also talk about adolescent-friendly space model. And here we are talking about a well-advertised adolescent space, which serves as an entry point service for adolescents visiting a health center. It's operated by designated healthcare workers and trained peer educators. And one thing to note is that these services that are provided to the adolescents are in line with the minimum health package. And the aim is to increase acceptability and utilization of health services by young people. So when young people come to the health facility, they want to see a face that is young like they are. And so this model provides basic health information, distributes information, education and communication materials, as well as contraceptives, and provides guided referrals to the health services within the health center and to other healthcare workers who may not be in the space, but are trained to provide adolescent-friendly health services. So the first poll, I think we have discussed that, yes, this is what it is. So we'll move on to our second poll. And our second poll reads, the following is true about adolescents in Zambia. So in Zambia, about a quarter of the total population is adolescents. B, investing in adolescent health has triple dividends, improving adolescents' health. Now, that's number 1, protecting the health of adolescents in adulthood. And thirdly, protecting the health of future generation, that's the offspring. C, improving general health outcomes for adolescents and young people remains a key priority area in Zambia, as a majority of adolescents and young people continue to face health challenges, or is it D, all of the above? So I'll launch the poll. So the poll has been launched. Let's participate in the poll. What is true about adolescents in Zambia? Is it a quarter of our population is adolescents? Or is it B, investing in adolescents has got a triple dividend? Or is it D, improving general health outcomes for adolescents and young people is a key priority in our country? Okay, so we have 40% of the participants participating. I encourage you to participate. We are not able to tell who has participated, but at least we were able to have an idea of what we understand concerning adolescent health in Zambia. So I'll end the poll and share the results. So this is how we have polled. Majority of the network feel D is a response, while some people on the network feel C, B, or A are the responses. So we'll proceed and we'll discuss as we go on. So, as earlier stated, adolescence is defined as a period of transition between childhood and adulthood. And it covers the ages between 10 to 19. This is a unique stage of human development because there are physiological, emotional, and sexual changes that occur that shapes a sense of identity and individual autonomy. So it's a stage where these adolescents who were children now want to develop individual autonomy and taking care of themselves as they transition into adulthood. So there are hormonal changes, brain development, and also personality traits that lead to new sets of behaviors and capacities that influence their social capital transactions in the family, among their peers, among teachers, and in their health behaviors. So despite being viewed as a healthy stage of life, so I must state that adolescence is a normal phase of life. We all pass through adolescence, and it's very normal for those physiological, emotional changes to occur. However, adolescents are affected by many health challenges, including illnesses and sometimes even death, most of which if are avoidable or treatable. So globally, adolescents make up 16% of the total population and 1/5 of the sub-Saharan African population. And in Zambia, a quarter, which is 24% of the total population, are adolescents. And so investing in adolescent health has triple dividends. So when we invest in supporting, it means they are going to be healthy now, and we are protecting the health of these adolescents as they go into adulthood. We are assured of having adults who are healthy and productive, and also protecting the future generation who are the offsprings of these adolescents. And so improving general health outcomes for adolescents and young people remains a key priority in Zambia. So what are some of these challenges that adolescents face? So adolescents face a lot of challenges, including limited access to knowledge and information on prevention, sexually transmitted infections, including HIV and sexual reproductive health information. They also face common health problems that include HIV and AIDS, malaria, STIs, nutrition, which can be either undernutrition or overnutrition. we also have a challenge among adolescents, which is early sexual debut, where adolescents engage in early and unprotected sex. We also have issues of sexual abuse on the rise among the adolescents, and we also have early marriages and pregnancies. We have transactional sex, transgenerational sex that leads to early marriages as well as unwanted pregnancies or unplanned pregnancies. We have seen drugs and alcohol use, and also mental health problems arising from there's so many things that these adolescents go through. And recently, as a country, we've seen things like drought, load shedding affecting our adolescents. So, looking at the challenges that these adolescents face, our Adolescent Health National Strategic Plan has got 6 focus areas. And these focus areas are in line with the challenges that these adolescents face. And so as we do any of the activities, we need to remember to think about sexual and reproductive health for these adolescents, HIV and AIDS and other STIs, sexual and gender-based violence, NCDs, as earlier stated, nutrition, mental health, alcohol, tobacco, and other drugs that are used by these adolescents. And also, the other focus area is adolescents with special needs, including those with disabilities. For a long time, I think we have challenges with IEC materials that target adolescents with disabilities. We may have IEC materials in languages, local languages, but again, that doesn't cater for adolescents who are blind. We don't have IEC materials in Braille and sign language. And so there's limited information that these adolescents can access in relation to health services. So our third and last point in this presentation is a true or false. Zambia has made efforts to improve adolescent health services, particularly in sexual and reproductive health, by establishing adolescent-friendly health services and youth-friendly spaces within health facilities. Do you agree with this statement? As a country, have we made progress in terms of providing health services through adolescent-friendly space models? What is your comment? Is it true or false? So I'll launch the poll. And this is our last poll. So the poll has been launched. Please let's participate. As Zambia made efforts to improve adolescent health services, what do you think as a healthcare provider providing services to adolescents in your facilities, in your districts? What is your take on this one? So far, we have 47% of the network participating. This is very good participation. We do appreciate that the network has taken interest to participate in the poll. It gives us an idea to appreciate what you feel about what the topic that we are discussing. So I'll end the poll right here and I'll share the results. So majority of the network think it's true that Zambia has made tremendous efforts in improving adolescent health services, and a few still feel there's something that we still need to do. So I'll stop sharing and then we'll see as we go. So when we look at adolescent-friendly services in Zambia, again, Zambia has made efforts to improve adolescent health services, particularly in sexual and reproductive health, by establishing adolescent-friendly health services and youth-friendly spaces within health facilities. And these initiatives aim to address the unique health needs of adolescents and reduce the barriers to accessing care, with a focus of making services more accessible, acceptable, and appropriate. So remember the 3 A's. These services should be easily accessible. Secondly, they should be accepted by the people that we are providing the services to, and they should be appropriate depending on the needs of the people that we are serving. So in this regard, we are talking about the adolescents. So the Ministry of Health here in Zambia has developed national standards and guidelines for the provision of these services. And these are the standards, I think, that we use to help us standardize the delivery of services across the country and improve adolescent health outcomes. So we use these standards, whether you're in Lusaka, you're in Northern Province, you're in Western Province, these standards are the same. And so these are the standards. There are 8 standards according to the Adolescent Health Strategic Plan. The first one is adolescents and young people's health literacy. The second one is stakeholder support. So it's important that as we plan to start providing the services, we work with our different stakeholders. Stakeholder mapping, very, very important, okay? And then we need to make sure that the providers are competent, are trained. We need to have appropriate package of services, equity and non-discriminatory. It doesn't matter the age, the sex, we need to provide the service, the education status, marital status. We need to have a standard of providing the services to everyone. And then data quality, very, very important. And we do reports through the Ministry of Health to make sure that these indicators or the services that we are providing are harmonized. And the last standard, so the last standard is adolescent participation, very, very important. In whatever we are doing, when we make decisions to provide a service to the adolescents and young people are key stakeholders in planning, monitoring, and evaluation. So these are the standards. So how can we finally support these adolescents to access the services? We need to provide the services in a more adolescent-friendly manner. We need to be more empathetic to the adolescents. Sometimes the way we treat them, we behave as if we were never adolescents and we never made mistakes, but it's inevitable. Sometimes those mistakes are made unknowingly, and so we need to be more empathetic as we provide the services as healthcare providers. Consider having a specific day or a space to attend to the adolescents. Provide the services where the adolescents are more comfortable accessing them. Is it at the health facility? Is it at the community level? Or is it maybe on a digital platform? Nowadays, we have apps where adolescents can access a counselor and things like that to understand the needs of the young people. We can't provide a service the way maybe services were provided in our days because we didn't have digital platforms. So we need to know where are we meeting the young people and how are we engaging them. And then finally, engage stakeholders. Here, when we say stakeholders, we are talking about the guardians, the parents, the community leaders, religious leaders. At this point, during adolescence, most of the adolescents are inclined to learning more about their belief in God. So if you go through their religious leaders, they are more likely to listen to you than anybody else. The adolescents themselves are key stakeholders when we make decisions. So what have we learned from the adolescent health services in Zambia? We have learned that adolescent-friendly space model, this is a well-advertised space which serves as an entry point for the adolescents accessing health services at the health facility. Be a space that is dedicated or a service that is dedicated to the adolescent provided by trained healthcare workers and peer educators that support the provision of these services. And we have also learned that investing in adolescent health has triple dividends. We improve the adolescents' health now. We make sure that they don't get STIs, they don't get HIV, and they grow into healthy adults. And therefore, we are protecting the future generation. If we have a generation that has a lot of HIV and a lot of infections, it means we are not going to end AIDS by 2030. But if we have healthy adolescents, then we are good to relax and know that we are going to have an HIV-free generation because they will not pass the HIV to their offsprings. So this is the end of part 1. And at this point, we'll not go through the poll, but we'll go to the next part of the presentation as I invite Team Matero. So we'll start with Matero and then we'll have the Rise Up. No, we'll start with Rise Up, okay? And then we'll go with to Matero. So here in the hub, like I said, I'm with Madam Gezire Tembo, who will take us through the next slide to share some best practices from the Rise Up project. Madam Gezire is the country program director from the Rise Up project. Over to you, Madam Gezire.
Thank you very much, Dr. Manzi, and good afternoon to everyone. Good afternoon on the other side, and good afternoon to everyone in the platform here with me. As Dr. Manzi has made mention, my name is Gezire Tembo. I'm the country program director for the Rise Up project. So basically, Rise Up is a project under the Historically Black Colleges and Universities Global Health Consortium. So this is a consortium of 4 schools here in Zambia that are funded work by the HBCUs. So we have different mandates, but specifically for Rise Up, we are targeted to work with adolescent girls and young women aged between 15 to 24. So we have our sister schools, that is Mehari, that works with MCH, Howard, that works with the DSD, Morehouse, that works with telemedicine, and us as Rise Up that are managing the adolescent girls and young women. So as for Rise Up, yes. So as for Rise Up, we're working within the overall PEPFAR target aim. That is the 95-95, mainly with viral load coverage, viral load suppression, and among others, different psychosocial activities that I'll be able to highlight in my next slide. So as Rise Up, we have 2 arms, and we work as a direct service delivery model, supporting the clinical-based arm and supporting the community arm. So what do we mean by the clinical-based arm? When we say the clinical-based arm, it means that we do replicate within our community spaces the activities that actually do take place at a facility within our community setup, that is the Rise Up House, or within the youth-friendly spaces. And we have our community arm where we do our psychosocial activities. That starts from community mobilization and different health packages. Just to name a few, we have what we call the sports and fitness, we have creativity, we have library, and we have our parents and caregivers meetings. So I'll make mention of the details as we move further. Next slide, please. So what is Rise Up? I think before we came into the picture, that was in 2017. So when we were looking at adolescent health, I think Dr. Manzi has done a good job in highlighting the many challenges that the adolescents are facing. We looked at the different health the adolescents are facing. We found out that there were high rates of HIV infection, poor adherence, limited health access for the adolescent girls and young women. And for the limited support and structures, we have seen that we have limited space, even just within our facilities for the adolescent girls, or rather the adolescents generally. And this is how come the Rise Up project now came in to have a direct service delivery model that will support both the community arm as well as the clinical arm. Then we also looked at how the the socio-economic barriers were actually having a direct impact on health outcomes of the adolescent girls and young women. And this is where we decided to couple our clinical arm with our community to ensure that we do provide empowerment activities, because we discovered from our interactions with adolescent girls and young women that by them not being financially independent or having some sort of income, they were unable to make informed decisions about their health outcomes. Next slide, please. So when Rise Up came into the address all those barriers that we found, and we have seen that there has been improved health outcomes by improved access to healthcare through our Rise Up houses, or rather our Rise Up spaces within the youth-friendly spaces within the target areas that we are in. So I must make mention that we are in 2 provinces, that is Lusaka and the Copper Belt. Lusaka, we're in Chilenje, Chawama, Matero, and Kanyama. Then for the Copper Belt, we're in Ndola. For Ndola, we're in Chipokota-Mayamba and Lumasala. And for Kitwe, we're in Chimwemwe, Abuchi, and Iposokilo. So this is where we're drawing all our results and our best practices as Rise Up. Next slide, please. So we have seen that we have seen a number of improvement, and this is where we want to share now with the network, including the ministry, to say these are the gains that we have seen, and this is what we're also trying to sustain beyond the Rise Up project. That is continuously improving the prevention for adolescent girls and young women by ensuring that they have good mental health amongst themselves. And we do have activities that do support that, specifically an activity that we're calling the Community Adolescent Action Group, which is a support group for the adolescent girls and young women that meet and are able to share the challenges, the barriers with treatment, and some of the experiences surrounding stigma, that is family stigma, that is self-stigma, and they're able to bring that to the table. And another activity that we do as Rise Up that we would also want to share with the network is our peer navigation approach. So we have our volunteers who are actually adolescents themselves or closer to adolescents, so that have just transitioned from adolescents, that are actually supporting these adolescents. As we've heard from Dr. Manzi's presentation, that this is a good practice when we see that the adolescents are actually being supported by fellow peers. And we've also brought in the aspect of empowerment. We have a couple of empowerment activities within our program that stems from gardening, baking, we have creativity, and these activities have actually helped the girls to make decisions beyond just them being empowered with health outcomes. They're also being empowered with economic access, and they're even able to negotiate for safer health access and outcomes for themselves, even just within the community. Next slide, please. So we have also seen from Dr. Manzi's presentation the importance of the physical space. So Rise Up has houses that are within the community that are providing this space for the adolescents. It's not a clinic, it's a Rise Up house that supports different services, both clinical, both psychosocial, and both community activities. So in this Rise Up space, we ensure that we provide different activities that will make it different from the facility. We have our computer lab that supports the girls that are actually studying to be able to prepare for their exams. We have our library that will allow the girls to be able to sit and also just do their study group meetings, because we know that the school libraries are congested and do not have enough books. Those are some of the activities that we do provide in terms of the community. We also have the movie dates. That is an avenue that we use in terms of providing sexual reproductive health education as an IEC material. For example, we have the commonly known Love Games series. So we beam that and we're able to interact with the adolescent girls and young women as they look at the real life issues surrounding HIV transmission, HIV prevention, and some of the things that they actually might be facing, and they're seeing that on TV. And this is where we actually bring out our topics in terms of what we're going to talk about. So this provides a conducive environment for the girls to be able to express themselves, to learn, and to also get access for their ART pickup and also their PrEP pickup. Next slide, please. So what are some of the benefits of this physical space? Be it in the community or at the facility, because we work both in the community as well as the facility. It's a youth-friendly, it's suggested for the adolescent girls and young women, and they feel comfortable enough because they're being attended to by their fellow peers. And we have seen that we have reduced healthcare costs in terms of some of these structures that we have within our facilities that are prefabricated specifically to provide those healthcare outcomes for the adolescent. And we have seen some sort of behavioral change as we have interacted with most of the adolescents, because we do have some adolescents that have been on the program for like 5 years or more by now, and we're able to see that not only are they improving their health outcomes or their empowerment skills, but we've seen that they're also sharpening their educational skills just by the different service provisions that we do have within our Rise Up spaces. Next slide. So what are some of the best practices that we have seen? So like I have made mention that we do have this Rise Up House. It has an aspect of a clinic just to ensure that we provide our ART pickup. So this particular room that looks like a clinic is actually an annex to the facility that we are in. For example, if we're in Kanyama, we have a Rise Up House in Kanyama. We're able to use the smart care within our Rise Up House to just check on the progress of this adolescent girl. And we use our service delivery points in terms of screening and just reaching out to the girls. So one other best practice is we learned post-COVID when we engaged telehealth. So we were able to provide these services by making phone calls, by sending text messages. That is the 3, you have the 6 days, we have the 3 days, and we have the day before in terms of reminders. It could be for drug pickups, it could be for PrEP services, and it could be generally for the activities that we would want to do with the adolescent girls and young women. And we have also taken the opportunity to engage with different stakeholders to be able to learn and provide these different services by the use of our physical space. And also we have fully utilized and enhanced the use of our social media platforms. So another important aspect that I would also want to refer to what Dr. Manzi had mentioned is the importance of engaging with parents and caregivers. And that is one of the best practices that we have seen, because it has created some sort of ownership, it has created some understanding, and we do get a lot of support from the parents and the caregivers within our target population. This has also bridged the information gaps of the girls and the young women between them and the parents, and they're able to fully understand the services that are being provided at the facility. So I'll give an example of how our different activities are intertwined and how they are providing different services. So we're looking at empowering pink girls. So what do we mean by pink? So we have our positive girls that we refer to as pink girls. So from missed appointments to a meaningful change. So I'll read out the story, so which talks about an adolescent girl that, or rather adolescent girls that were identified from Matero and Kanyama and were living positively and were at high risk. And they were consistently missing the appointments due to poverty, stigma, status denial, and lack of disclosure. So recognizing the standard adherence, counseling, and inefficiency, the team decided to do a holistic empowerment-based approach. So with the peer support, we're able to provide the vocational skills training for baking and tailoring to these 37 girls. And a unique story that we're going to highlight is of a girl who is 19 years old, who defaulted on ART for nearly 3 months, lost hope, and rejoined the tailoring group. Then she gained a renewed sense and was motivated to resume work. So she's now adherent. She serves as a peer navigator, inspiring other adolescent girls and young women. So in terms of the Rise Up programming, we're able to see that we're marrying the clinical services to empowerment services, as well as the community services, whilst also fighting stigma and supporting the girls to thrive within their health outcomes. So another success that we've seen as Rise Up is basically just engaging with the parents and caregivers. I cannot overemphasize this. We have received a lot of support from the parents and caregivers, and they are now like our advocates and ambassadors within the community in ensuring that IEC materials or information about adolescent health, that is retention and prevention, is actually disseminated within the community. We have parents calling in just to get information. We have parents actually volunteering their spaces for us to actually sit there to have meetings and interact with adolescent girls and young women. Next slide. So what are some of the examples of the activities that we do have at the Rise Up spaces? We have, like I earlier made mention, we have our movie dates. This is an avenue where we ensure that we provide sexual reproductive health services, as well as IEC material. We have our computer labs, and we have our social media presence. So we do this both within the Rise Up houses, and we also do that within the youth-friendly spaces. So what are some of the recommendations for sustainability? We know that we cannot manage the adolescent health alone as Rise Up, as you can already see that we're only working with adolescent girls and young women. So we decided to come to this platform and share with the network some of the recommendations from our experience of sustainability and just working together from for the provision of better outcomes for the adolescents. So we have seen that engaging with the schools, in terms of Ministry of Education and Higher Education, has really provided a larger platform for us to be able to actually even emphasize the aspect of comprehensive sexuality education just within the schools. This is one of the avenues that is cost effective, and you actually leverage on the different stakeholders within the community, or rather within the schools, to just be able to provide this service. Support the youth-friendly services by ensuring that you're active. I know we're so many stakeholders within the youth-friendly space, all of us ensuring to provide the most appropriate services for the adolescents, and hence working together, even just doing a community activity together with the different stakeholders has really helped Rise Up. And also supporting events like the sporting events. This brings out momentum. It provides for us like mass testing, and we always work in collaboration with the facility. And even as we're fast approaching our HTCT day, I think this is one thing that we can also consider as those satellite activity. Then we also have seen collaboration with the churches and the gatekeepers. I think that was something that was also made mention, and the use of social media, as I earlier alluded to. Next slide, please. So that is about Rise Up. Thank you very much for giving me this platform. If there are any questions and concerns, please feel free to ask away. Thank you.
Thank you so much, Gezire, for that wonderful presentation. A lot of best practices coming out from the model that you are implementing. I like the fact that you are dealing with both those that are HIV negative and those that are HIV positive. within the same space. And it's good to know that you're able to strike the balance and meet all of them and their needs. Yeah, and also the fact that you are working with the different stakeholders just to make sure that everyone is providing the services without duplicating the effort. So I like those coming out in the presentation. I think there are some questions in the chat, and I've seen one or two that have been responded to from our colleagues from Charles Drew University. And now we'll finally move to the few slides from Matero. I have not seen Sister Samiah on the call unless she's logged in using a different name. Sister Samiah, are you on the call? Kindly confirm. So Sister Samiah is the adolescent focal point person from Matero Level 1. And Matero Level 1 is showcasing the best practice of implementing a one-stop model. So this is Matero Level 1 Hospital Adolescent Youth-Friendly Space. Sister Samiah, are you on the call?
Yes, I am, Dr. Manzi. Thank you so much.
Thank you. So, Sister Samiah, I want you to take us quickly through the presentation. So, over to you.
Thank you so much. What we're looking at is the youth-friendly space. This is the shelter that has got IEC material printed on it. And then this is the inside of the youth-friendly space. This is the waiting area, and the other side where there's a window, that's the counseling room. Next slide. So the services provided at the youth-friendly spaces are HIV testing and counseling. We are offering HIV prevention, that is PrEP, PEP, and condoms. We are offering HIV treatment and care, which was recently started in February. We are also offering family planning, particularly short-term methods. We are screening for mental health, specifically substance use. We are also offering IEC materials on sexual and reproductive health. We are offering support group, youth group, and we also have referrals that are normally exported, the VMMC, the long-term family planning, CAC, which is comprehensive abortion care, cervical screening, GBV, mental health treatment. So these are these referrals, mostly we do escorted referrals. The human resources that we have in our space, we have an adolescent focal point person, that is one. We have the clinical officer who is supported by Rise Up, which is one. We have a psychosocial counselor who is also an assistant adolescent focal point person. We have peer educators who are 4 and 2 counselors. We have volunteers trained in adolescent health, 6. We have 4 peer educators who are trained in peer education. We have 2 adolescents who are trained, 2 active adolescents who are trained in family planning, the short term. And then we also have 2 psychosocial counselors who are trained. Next slide, please. The stakeholders that gives us support at our youth-friendly space. We have LPHO, and the type of support that they render is HIV treatment and care, support groups that include those the pregnancy and breastfeeding, those who are on treatment, and the caregivers, and then community outreaches and trainings. And then we have Rise Up. I think Rise Up, Gezire has mentioned more about Rise Up, what they do. And then we have grassroots soccer. Grassroots soccer, they use the power of soccer to educate, inspire, and mobilize Zambian youth to stop the spread of HIV, using the Skills Plus to HIV adolescents. They also offer mental health education, particularly depression, anxiety, and stress. And then we also have TICO. TICO, they provide HIV prevention through demand creation. We've got NZYP Plus. They look at adolescent and young people living with HIV and disability to train to be advocates and to be resilient. We also have Bupe Musonda Foundation. Bupe Musonda looks at people who are HIV, adolescents who are HIV, the vulnerable children, those with single mothers, or parents with school sponsorship support, and with school essentials such as books, uniforms, shoes, pens, etc. And then we also have Zafod, who advocates for the promotion of disability rights for adolescents. And then we have SAT. SAT, they are into HIV prevention through demand creation as well. Water Aid, they're supporting in terms of water and sanitation. Lastly, we have NZP Plus, who aims to improve the quality of life of people living with HIV. Next slide. Okay, so the best practices that we have for Matero, I must say, Matero Level 1 Hospital is one of the facilities that has got an adolescent focal point person stationed at the youth-friendly space. And this was made possible by our matron Bota, who is very passionate about young people. So this one is the best practices, the best practice for Matero. And because of this, we're able to offer services including HIV treatment and care in the space, because there's a nurse stationed at the youth-friendly space. So to continue the best practices, we offer a wide range of integrated services, including HIV treatment and care, PrEP, PEP, STI screening, of which these ones we never used to do previously because we had a small room. We also offer this mental health support and family planning all in one convenient place. So all these services are offered at one place. And then we also have 2 trained peer educators who are available to provide short-term family planning services and support. This for Matero we never had previously, but now we have 2 peers who are trained. And then adolescent peer supporters trained in counseling are actively involved in offering guidance and emotional support to their fellow youth. And the stakeholder mapping and engagement has helped the facility identify all those that they can work with and the kind of support they can get from them. So this one has really helped us as Matero, even for us to have that bigger space. It is because of the stakeholders that we have. They made it possible for us to have a bigger space, a space that has been branded with IEC material, such that when an adolescent enters the facility, even if no one has told them where it is, they're able to tell where the youth-friendly space is. So this one is the best practice. We can move to the next slide. So we have healthcare providers uphold a warm, respectful, and non-judgmental approach, helping adolescents feel safe and valued. This one is very cardinal at our youth-friendly space, because we believe adolescents, they want a space that they can walk in and feel at home, not a place where they feel judged, they feel not respected. So this one is very cardinal at our youth-friendly space, whereby each provider is supposed to uphold this. So this one, I must say, we are doing. And young people are empowered to take charge of their health by being encouraged to take part in scheduling their own appointments. So you find that these adolescents, we have so many types of adolescents. We've got adolescents who are working, we've got adolescents who are in schools, we've got adolescents who are not doing anything. So when they come for the appointment, we ask them, when are you free? When can you come for your next appointment? So we give chance to an adolescent to choose whether to come during the week or during holidays or even Saturdays. We give them chance to choose what works best for them. And then confidentiality is prioritized at every stage of service delivery to build trust and encourage open communication. You know, an adolescent, the moment they see that this space doesn't uphold or confidentiality, it is very difficult for that adolescent to come to that space. So with this, the youth-friendly space has made it possible that the space has got confidentiality and it is always prioritized so that an adolescent is encouraged to come through to the space. And then the space is designed to accommodate adolescent-focused health talks, interactive sessions, and peer-led activities that promote healthy styles. I think from the beginning of the presentation, we saw our infrastructure, how it is. It has got a shelter where adolescents are able to sit and to have interactive sessions with their fellow peer educator, because most of the time these adolescents, they listen more to their friends than to the older ones. So the peer educators in our youth-friendly spaces are the ones who lead everything in the space. Us, we're just there to guide and offer other services that they can't give. Next slide.
That was the last slide.
Thank
Sister
you so much
Thank you. I know you were
breaking.
Yeah, thank you, Sister Samiah. I know you were breaking here and there, but very nice presentation there, showcasing some best practices from Matero, starting from the infrastructure that has been improved to provide privacy for the adolescents to have meaningful discussions, leadership involvement, the bold step taken by the leadership to assign a healthcare worker to the space really shows us that we are prioritizing adolescent health in our facilities. So kudos to the leadership at Matero, they've one hospital. And also adolescents taking ownership of the activities in the space is a best practice we have seen from Matero and something to emulate in other facilities. So looking at time, if you have any question or comments, I've seen the chat is active. Please do post in the chat so that we allow our colleagues sharing a case from Winnie Lunga to do so. Do we have Mr. Alex Phiri on the call? Mr. Phiri, are you on the call?
Good afternoon, yes, I am on the call.
Thank you so much, Mr. Phiri. So we are moving on to the case presentation.
Okay.
Yes. So, Mr. Phiri, are you able to see the presentation?
Yes, I'm able to see it.
Okay. Okay, just a minute. Just a minute. Just a minute. We put it in slideshow so that you are able to proceed. So Mr. Alex Phiri is a clinical mentor from Winnie Lunga district. in Northwestern Province. And he will share with us on behalf of the district hospital. Kindly confirm you're able to see the slides.
Yes, the slide is visible. Thank you so much.
The slide is visible.
You can proceed, Mr. Phiri.
Thank you so much for that introduction, for introducing me. Otherwise, the team, GHO and hospital team with me. To go through our case, this is a case of JN, a female, 18 years old, who came to our OPD with presenting complaints of a cough, which was productive for 5 days, with no abdominal pains and genital sores. Fatigue was also noted for 2 weeks and weekends. Medical history, past medical history, we didn't have hypertension, no DM, no epilepsy, and no history of HIV status was unknown at the day of visit. Social history. This is an adolescent in a shanty compound of Mwinilunga with a single mother. Her parents divorced in 2022. She's a dropout from school, which was in 2023. Currently, she's enrolled in G9, in grade 9, GCE, and sexually active, but was hesitant to disclose the sexual partners. However, counseling was done, and we managed to elicit one adult male who's a cross-border trader and was not traced. Our adolescent drinks alcohol. She disclosed only on special occasions such as Christmas and New Year, and does not smoke. The last menstrual period was February 22, 2025. On drug history, she self-prescribed metronidazole and paracetamol for 5 days with no improvement. No history of drug allergy, not married, and has no child. Vitals which were taken, BP was at 109, 99, pulse 90, respiratory rate it was at 21, temperature 26.8, and weight was at 38.1 kg, height 165, giving us a BMI of 14, which was low for this adolescent. On physical examination, our client was stable, no jaundice, no pallor, no cyanosis. The chest was clear. S1 and S2 were regular. Then the abdomen, it was soft, lower abdominal tenderness, and no palpable mass was felt. The vaginal examination, the vulva was fresh, round, and firm soles on the labias with a visible discharging Bartholin gland was seen. Vagina was warm and moist, with adnexia tenderness on cervical excitation. Pulse mating was also observed from the vagina, and the vaginal discharge was also noted with no active bleeding. Our client presented very emaciated, no pedal edema. The nutrition status, this was malnourished. Our differential diagnosis was genital discharge syndrome, syphilis, Bartholin abscess, and pulmonary TB. Our plan A investigations, we did a DCT, which came out positive, and our client was referred to ART. RPR was also reactive. Urine routine microscopy and examination was done. FBC, chest X-ray was ordered, but was not done. Hepatitis B came out negative. Gene expert, MTB, not detected. Urine lump was negative. CD4 count by use of VCTech, it was above 200 cells. Our baseline viral load was close to 2 million, which was 1,877 658,000 copies. Cervical cancer screening, use of VIA was negative. Plan B treatment, adherence counseling was done, disclosure counseling, indexing, and social network testing was done. On indexing, we only managed to elicit one sexual partner, as earlier alluded. Treatment, ceftriaxone 2 grams start was given, metronidazole 400 milligrams for 5 days. TDS was given, Doxil 100 milligrams BD for 7 days was administered, and benzathine penicillin 2.4 mega once weekly for 3 weeks. We also offered nutritional counseling, then commenced our client on ART, on TOD. Then this client was given second dose of benzathine on 10th of March 2025 in OPD. We reviewed our client in ART on 17 March 2025. The client was responding well to treatment, and new vitals taken at this visit was BP 120/70. Weight, we saw a 2 kgs rise in 2 weeks, which went to 40.2 kgs. We therefore initiated our client on TPT ARVs dispensed for 1 month, and on our next visit, a date which fell on 16 April 2025, we did not have any new complaints. The client was responding well to treatment, and our new vitals were BP 117/65, weight 45 kgs. We saw another rise in weight gain by 5 kgs. Adherence counseling continued with an emphasis on condom use. BMI rose from 14 to 18. 3 months post-initiation, which was 16 June 2025, we reviewed our clients with no new complaints. The client was in elated mood. The BP reading was 128/83. Weight, we saw another rise to 46.5 kgs, and our client is currently on treatment. Next slide. This is a summary of our lab, which was done. So our CD4, as earlier alluded, was done on 3rd March 2025 and was above 200. ALT was not done. We do not have reagents, same as creatinine. Hepatitis was negative. Viral copies close to 2 million. Regimen was put on TOD. RPR was reactive. Cervical cancer, VIA negative, and TB LAM also was negative, including gene expert. On urinalysis, we saw packed sparse cells and numerous epithelial cells. On gram stain, we had diplococci gram negative. Next slide. So that is how we manage our clients and the team. With me here in Mwinilunga, we have our 3 questions, which the first is, how best could the team have elicited for more information from the adolescent? Second one is, Mwinilunga being a fast-growing district with mining activities, a rise in STI cases is expected in the adolescent age group. How can we support adolescents like JN to access sexual reproductive health services? The third one is, what challenges do providers and adolescents face in facilities without adolescent-friendly spaces, such as our case in Mwinilunga? Thank you so much.
Team, are you still there? Mr. Phiri, you seem to be breaking. The last question from Mwinilunga team is, what challenges do providers and adolescents face in facilities without adolescent-friendly spaces? So just a summary of the case presented by our team from Mwinilunga. This is a 17-year-old adolescent who's newly diagnosed with HIV, and also has syphilis and a battle. And this adolescent received the services at the health facility in OPD and was referred to ART, where ART was initiated, and also index for sexual contacts was done, as well as social network, with one contact who's a truck driver, a cross-border truck driver, was elicited. So the team in Mwinilunga, it's evident from the lab results with a baseline viral load over 1 million copies, almost 2 million copies, a new HIV infection. The team in Mwinilunga is trying to find out how best can we talk to adolescents who seek services to ensure that we are able to elicit that information to help these young adolescents. The second question is, how can we support adolescents access sexual reproductive health services so that we don't get them at a point when they are infected with HIV? And the other one is, we've seen the presentation earlier talking about adolescent-friendly spaces, but it's not all the facilities that have. Mwinilunga District Hospital doesn't have an adolescent-friendly space. So how best and what challenges do providers working in these facilities face, as well as the adolescents themselves? They go in a facility, they don't see any adolescent-friendly space. What challenges do they face? So at this point, I would like to thank Mwinilunga team and open it up for discussion with the network. If we have any questions or clarification before we respond to the questions. Do we have any questions or clarification? Okay, Mwinilunga team, you would like to respond to the question in the chat? You can proceed. Yes, you can unmute and proceed. There's a question. Yes, you can proceed.
This is clear. We don't advertise as a good earlier one. So the other question that I have, maybe I wanted to link it was quite a good presentation. Looking at the issues related to best practices, we are just asking now, how are you involving the youth makers to ensure that the good works of Zambia continue as sustainable? It's a very good model, it's a lot of investment. So how is probably I'll start from that before we come to answer our questions.
Thank you for that. Though you were breaking, so I was not able to pick the question clearly. You can still type in the chat so that we're able to respond to your question. Do we have any other clarification that we need? So Team Mwinilunga has responded that they do not do titers for RPR, so they were not able to do that to tell whether it was a new infection, or also follow up the treatment to see whether it has cleared or not. So at this point in time, as a network, can we help Team Mwinilunga? I know there are experts on this call. I'm not talking about the panel of experts here, but people who are well vested in handling adolescents and also getting information, especially in terms of elicitation and also social network. We've seen social network work where adolescents are able to reveal their adolescents that they hang around with and also having high risk activities with. So do we have anyone who would like to give a go to the first question before I ask my experts, the experts on the panel? Anybody on the call? Ngosa, your hand is raised. You can proceed to give your your input.
Good afternoon, Dr. Manzi, and good afternoon, everyone. I am Ngosa from Rufunsa. So my contribution to the first question is that probably what they can do is continue engaging these clients at every visit to try and elicit more contacts, and then also personalize the service provision by not changing the persons who are attending to this client until a point comes when this client is seen to be stable and they have given us enough contacts for under elicitation, and then also ensure that there is continued IEC on the importance of this client disclosing the sexual partners, so that the spread of the diseases that she's been found with, like syphilis and the infection of HIV, is stopped. I submit.
Much, Ngosa, for that submission. Indeed, you brought out the issue of personalized care and also pairing. In this case, if at all there is a younger counselor who can provide that counseling to this adolescent, it will go a long way. And also creating rapport and trust goes a long way in as much as opening up and sharing about their other sexual contacts. At this point, I will also ask one of our experts here in the hub. I've got two experts. I've got Madam Inutu Mbangweta and also Dr. Khozya Zyambo. We are together in the hub. So I'll ask Madam Inutu to give also an input on how best we can talk to adolescents to get more information, and how we should talk to adolescents as healthcare providers as we interact with them. Inutu, over to you.
Thank you very much, Dr. Manzi, for first of all, let me begin by commending the Mwinalunga team, in particular, Mr. Phiri, for that presentation about our young person, an adolescent age 17 years old, JN, newly diagnosed HIV positive young woman. I must say that the team indeed managed to get quite a lot of information from the young person, but as they have asked, more could have been done. Let me begin by saying that, adolescents, when they come to the health facilities, they are looking for a welcoming environment. They want to be quickly attended to. They do not wish to get approval from their parents or guardians about them seeking care. They want to see that confidentiality is maintained, privacy is given to them, and they want to be attended to in a one-stop center. And also they want to be respected, just like any other person wishes to be respected by others. So we hear from the presentation that JN could not disclose the partners or her partner, whether it's one partner or more partners, she couldn't disclose about that. So now, what could we have done better? In the adolescent health provision, we normally advocate for the use of what we call HAIDS. HAIDS as an acronym, where we have H H standing for home, E standing for education, A, activity, D, drugs, S, sexuality or sexual activity, and the second S, suicide or depression. So let's begin with the H, which is the home. We heard from the presentation, the team from Winrunga informed us that this young person came from a shanty compound. Well done. But we could have heard more about this person's home. We heard also that she lives with her parents, but we could also have heard whether who is in that home, apart from the parents or the guardians. Do they have any new people in that home? We see that she has HIV. Could that HIV come from within the home, or it came from outside the home? Then when we come to the second acronym, which is E, education, I think they gave us something about she's a grade, is it grade 9 or something like that? But we could have also heard more from her to see how is her performance at school. Is she doing well? Is she missing classes? How is she relating with the teachers? Why do we want to hear this information? Because we know that most of the adolescents don't have physical problems. There are very few that have physical problems. Majority of them, even the physical problems that they get, come from risky behaviors. So it's very important for us to know about the education of J. We could have heard more about her education. We could have also found out how she's relating with the teachers, because now she has been found HIV positive. Is she in boarding school? Is she a day scholar? We are talking about adherence issues. How is she going to adhere to her drugs? When we go back to the H, the home, who is going to support her who is going to be her buddy? At school, how is she going to continue to take the drugs? Is she in good relationship with the guidance teachers, for example? Does she know the guidance teachers? So that if she's in boarding school or even in day schooling, we have these days in education, even in schools, the guidance teachers do help the young people to take their medication so that they remain virally suppressed. Then we come to the A. Remember I said heads, HEADSS. So when we come to A, we did not hear much about the A from the presentation from Mwinilunga. Does this young person engage herself in any activities? Does she play any sport? What does she do in her spare time? Does she watch TV? What does she do with her phone? What does she watch on the phone? All that information will help us to elicit more of her risk behavior. Then the D, the team attempted much to get more information about the D, and I'm happy we heard that she's a non-smoker, she doesn't take alcohol, but we don't know whether this is true, especially that she could not even disclose her sexual partner. Adolescents, normally it's hard to get things from them. You need to, first of all, establish a very trusting relationship with them. Otherwise, they'll just be giving you information just to get rid of your question. Do you take alcohol? No. Do you smoke? No. And you'll be documenting that this person doesn't smoke or drink. So it's important that you engage the young person, you get a trusting relationship with them before you even proceed to find out about whether they smoke, drink, and so on and so forth. But also, when you want to ask about drugs, these are very sensitive issues. For drugs and substance use, it's very, very sensitive. None of us will just come out, even adults, and more so for the young people. The first thing is, let's also find out what substances are used in the area. If you go direct to ask the young person whether they drink or smoke, they'll just say no. But if you try to go it round and find out from them what kind of substances do they use in your area, what is it used? What do most young people use in your area? Then you can narrow it down to them and find out whether they do use the substances that they mentioned. For those ones that are engaged or they use substances, most of them, they'll quickly give you information about the substances that are being used here and there. Then you will know that where did this person get this information? And then you dig further to find out whether really they are substance abusers. Then the second one is the S. The first S is about sexuality. And I don't know whether the team did find out from the JN. Okay, I know that she couldn't disclose her partner, but we could have engaged her more to find out if we had established a relationship that is trusting. We could have found out from her whether she has a partner, how many partners, is it one kind of sexual activity do they do, or is she engaged in? Is she masturbating? Is it just sexual with activity with an opposite sex, or is it with the same sex? All that information is important for us to get from the young person, apart from the issues of finding out her LMP. Then when it comes to the last S, which is about suicide, I didn't hear much of it from the presentation from Winulunga. It's important for us to know whether this young person has had any suicidal thoughts. Does she have mood swings? Does she get more boredom most of the time? And all the other things that are related to suicide and depression. So I must say that Mwenilunga team did their best, but we could have gotten more information. Apart from that, we could have also come into the issues of linkages. How did we link? Was this young person linked to to support groups? Was she linked to any even social organizations, if there are any social organizations in Mwinulunga? So much could have done in order for us to elicit more information. Maybe also quickly, I can also add to the question of whether how could we help her to access sexual reproductive health? The adolescent-friendly space is the way to go. From JN, we have seen that JN went to OPD. Most likely, she did not even know about the space. Most likely, Mwinulunga may not even have an adolescent health space. So it's important that we have a space. And when we have an adolescent-friendly space, this is the first place where a young person must go to when they come to the facility. If we are able to assist them in the space, well and good. If we can't, we can refer them to the facility, within the facility where they can get the service. When the service is provided to them, at the end of the day, before they go home, the adolescent-friendly space, again, should be the last place where they live, so that it is from there that they are helped and given more information about sexual reproductive health and where they can access the services where possible. So let me stop here, Dr. Manzi, so that I don't take the show for myself.
Thank you so much for that input. I think we just need more time to discuss adolescent health issues. Madam Inutu is someone who's passionate. She's an adolescent. She's an adolescent at heart, and just making sure that we are improving adolescent health services that we are providing. So seeing that we are at 16, I would like to give Dr. Khozya an opportunity to respond or to say something about question 2 and 3 as we wrap up. How can we support adolescents access the services, and how can we support the healthcare workers in these facilities to provide the services, whether there is a space or there's no space? Over to you, Doctor.
So good afternoon, colleagues. This is a very, very important session that we have had, and I want to just appreciate the various teams that have been involved in the building up of this presentation today. Munilunga, well done. That was very good. Clinical management of this particular adolescent. We're very happy that from being malnourished now, she's well nourished. But then we also understand that we need to treat the person as a whole. And it's good you have these additional questions that are quite important. And I think Madam Inutu has done an excellent job of highlighting our response to some of these questions that you asked. And so I think from the Ministry of Health point of view, the goal is really to have an adolescent space in every facility so that we can be responding to their needs. And because we know that adolescents require special attention, and we need to make sure that spaces are created. And then also we need to make sure that we have got staff that have been trained in how to handle this particular group of people. And their risk for acquisition of these sexually transmitted infections, teenage pregnancies, alcohol dependence, even depression, anxiety is very high during this period, particularly if they get HIV infection. And so we need trained staff to be able to support and provide care. So that's quite an important aspect, and we need to strive towards that. And so we are really hoping, and I know Mwinilunga, we are not yet there in terms of supporting, because we do have a program that we're running under the Global Fund, where we're supporting Ikeleng, and Mwinilunga wasn't really on the list, but it's important that you begin to identify spaces that you can provide that support. Then also you identify, if you don't have spaces, you actually have to have some days when you can actually provide care for the adolescents. Even just a special day that is set up and you engage the community that on such a day, all adolescents are free, they can come through, we are going to attend to them so that we provide the necessary care that we need. And also, let's also address the issues of prevention. Let's not get them at the end where they've got all these opportunistic infections, they've got all these problems, but let's get them very early. And so we need to improve on our prevention services. And that would be very important in terms of preventing sexually transmitted infections. So we need to provide them all that they need in terms of condoms, in terms of contraceptives, in terms of having access to PrEP services, all those things that will help them prevent these infectious diseases. We need to do that. So I think, like Dr. Manzi has put it, I think we will need another session. I think particularly in this case to talk about how the approach to attending to adolescents, so that we can train everyone that is connected here, so that everybody becomes an adolescent champion like Madam Inutu here. So we are going to invite you to come and just talk about heads in details, because I think I like that approach. And so we'll be calling on you to do a presentation on that. So thank you so much, Dr. Manzi. Thank you so much, Madam Gezire. Good to see you. And our colleagues out there, have a good day. Thank you.
Thank you so much, Dr. Khozya, for wrapping it up so well. I think we had a good team in the hub and we had a good session, and we look forward to further discussions. Mwinilunga team, well done. I think this is a starting point. You shared the case and a lot of things have come out. Let's make sure that we follow this, the standards that have been provided by Ministry of Health, engage stakeholders and support healthcare workers that are championing adolescent health services. I would like to thank everyone, my experts in the hub and also those that joined remotely, Sister Samiah and Material team, thank you, Team Mwinilunga, and all of you that logged in up to the end of this session. Thank you so much. We look forward to seeing you next Monday for another yet interactive session. Thank you and bye.
Bye-bye.
Thank you. Bye.